Hi, and welcome to the Journal of the American Society of Echocardiography podcast in collaboration with the Canadian Society of Echocardiography. My name is Dr. Amer Johri, and it's my great pleasure to be joined by an esteemed panelist today. So our first panelist today is Dr. Anthony Sanfilippo, who is a professor of medicine and cardiology at Queen's University. He is the past president of the Canadian Society of Echocardiography and primary author of the Canadian Consensus documents regarding standards for the practice of echo. He serves as the primary advisor and chair of the Echo Accreditation and Quality Improvement Panel for the Accreditation Canada Echo Quality Improvement Initiative. He's also author of a new book, The Doctors We Need: Thoughts on the Training of Medical Students to Become the Doctors Canada Needs. Our second panelist is Jennifer Mercandetti, who is the Manager of Non-Invasive Cardiac and Vascular Services at the University of Colorado Hospital. Welcome, Dr. Sanfilippo and Jennifer.
Thanks for having me.
How are you guys doing today?
Very well.
Doing very well.
And Jennifer, can you tell us a little bit about where you're at right now and what's the weather down where you're at?
The weather, I'm not sure. I came in so quickly this morning, but I am currently in my office, university hospital, dealing with a very large inpatient list and staffing challenges. So I want to say it was about 60 degrees this morning. I did, as I was walking in across the windows, though, see a large flock of Canada geese and immediately...
Oh, no.
Now, do you hate Canada geese as much as we do in Canada? Like, they're kind of pests for us.
So in Colorado, I want to say it was around the time of COVID, they actually did a culling.
Oh, my gosh.
And the rumor is that they fed those geese to people, like they slaughtered them and turned them into turkeys. So,
oh my goodness, into turkeys. Interesting. Wow. I hope the economy is better now. So anyway, Dr. Sanfilippo, how's your day? How's your morning going?
It's going fine. It's a beautiful fall day in Kingston, which means it's cold and sunny.
Yeah.
But it's been great.
Great. So I'm going to get you, Dr. Sanfilippo, to introduce Dr. Picard. Then we will proceed to our presentation today.
Well, it's a pleasure always to introduce and to meet with Dr. Picard. He and I go back many years in echocardiography and in Dr. Wayman's lab in Boston. Anybody who's been involved in echo over the decades will not need me to introduce Dr. Picard because he's been a leading figure in the field of echocardiography. He's led one of the largest echo labs in the world, really, through all the changes that have occurred in echo over time and all the political changes as well. He's taken on leadership positions with respect to the development of guidelines for the use of echo and within the American Society of Echocardiography, where he's become both the president at one point and the editor of the journal, which is a huge responsibility. And it's something that's not just trusted to anybody. The fact that he was asked to do that speaks, I think, volumes for the trust that the echo community has in him. He's going to be chatting with us this morning about a really interesting study that, again, is part of that translation of clinical research to the clinical environment. And he's well suited to do that because in addition to his skills as echo, he's a clinician. He knows about patients, he cares about patients, and he understands what they need. So it's a real pleasure to welcome him this morning.
Great. We'll get the slides on our screen. And just to mention that this is a recent publication that appears in the June 2025 edition of the Journal of the American Society of Echo, entitled Stress Echocardiography in Patients with Moderate or Severe Myocardial Ischemia, Insights from the ISCHEMIA Trial.
Great. Well, thank you, Amer, Tony, and Jen. It's great to share this information with all of you. So let me start by explaining a little bit about what the ISCHEMIA trial was. The ISCHEMIA is an acronym for the International Study of Comparative Health Effectiveness with Medical and Invasive Approaches. And what the goal of this study was to really look at whether if you had stable ischemic heart disease, whether it is best to take an initial approach of going to the cath lab, doing angiography, finding lesions, and then revascularizing, whether with surgery or stenting, and then also getting a guideline-directed medical therapy versus just not going to the cath lab and having medical therapy alone. To get into this trial, you had to have at least moderate myocardial ischemia. Many of the trials before this that looked at this question or tried to answer this question really was not enriched with patients who had significant myocardial ischemia. So the really unique aspect of this study was that to get into the study, you had to first have a stress test that documented that you had moderate or greater myocardial ischemia. At that point, you then underwent a coronary CT to make sure you didn't have left main coronary disease, which would be treated differently, obviously, more aggressively. Also, that you didn't have no coronary disease or no significant coronary disease. We wanted to make sure everyone had at least one lesion that was 50% stenotic in a major coronary vessel. I should also say that all the patients also had to have an ejection fraction at least 35%. And again, these were stable patients, so no acute coronary syndromes. You had to have had stable symptoms for at least 2 or 3 months. These were not acute MI patients, et cetera. So it's a very typical population we would see in outpatient practice. And the outcomes that we looked at were cardiovascular death, a non-fatal myocardial infarction, hospitalization for heart failure, unstable angina, or successfully resuscitated cardiac arrest. And the data was followed for, the trial patients were followed for about 5 years. So we have a median follow-up of about 3.2 years. And in the end, the study showed that invasive strategy did not provide any additional benefit compared to just optimal medical therapy alone, which was somewhat surprising, I think, to many cardiologists. And from this study, we've generated many sub-studies, and in fact, we've even done longer-term follow-up now up to about 10 years of these ischemia trial patients. And again, still showing that the same findings hold, that really optimal guideline-directed medical therapy is comparable to a more invasive approach in these patients with stable coronary disease and a moderate ischemia. Now, about 20% of the patients, of the 8,000 patients that were enrolled, had a stress echo as their entry stress test. So we had this large database of patients with stress echoes who also have a coronary CT. They have been followed for many years with really good follow-up. They've been on optimal medical therapy in both arms with trial coordinators that were really obsessive about making sure patients stayed on their medical therapy, so good compliance. So we have this really a nice data set of stress echoes. And so my paper that was published in June in JASE really looked at many of the aspects of the stress echo, particularly with a focus on diagnosing or how the coronary CTs correlated with the stress echo results, and also, importantly, prognosis. What features on a stress echo connoted an adverse outcome? So I'll take you through some of the aspects of the trial. I think I've talked about all of these, other than you can see the exclusion criteria on this slide. Again, I've focus on. These are stable patients with ejection fraction more than 35%. They didn't have significant heart failure symptoms, and they didn't have really bad angina once they were on medical therapy. So again, the first step is, how do you define moderate or greater myocardial ischemia? And what we did was we looked at the prior studies that had stress echoes and outcome data. And what we found was that typically, if to have a 5% adverse event rate, you had to have a stress echo that had at least 3 segments that developed wall motion abnormalities, either hypokinesis or akinesis. And so we used 3 as our determination for 3 segments as a stress-induced wall motion abnormalities as our definition for moderate. More than 3, 4, 5, 6 would be severe. And if you had less than 3, that was mild. And obviously, if you had no wall motion abnormalities, that was no ischemia. The other thing we did was everyone had their volumes measured by the biplane method of DISC at both rest and at peak stress. So we were able to see whether volumes increased or decreased and whether the ejection fraction increased or decreased during stress. And we defined transient ischemic dilation, which is typically quantified in the nuclear lab during nuclear perfusion imaging, but we defined it on echo as a greater than 10% increase in the volume of the ventricle, the end-systolic volume of the ventricle at peak stress. I mentioned our primary endpoints, and then we also had a secondary endpoint of quality of life, which was based on angina questionnaires. So really angina as how severe the angina was, both beginning and then during the trial. This was a central illustration of our paper, and I'm actually going to skip it because we're going to go into detail of some of those tables. So we'll skip through it. So as I mentioned, we had a large number of patients. We had over 600 patients that had a coronary CT that you could identify at least a 70% lesion, and that's what I consider a significant lesion, who also had a stress test. So we had a good number of patients to study. And on the right-hand side is the consort diagram that tells you the breakdown of, we started with 8,500 patients. We got down, those who were enrolled and screened, and then more than 5,000 were randomized into the trial. And I said about 1,100 of those had a stress echo as their primary test to get into the trial. So this table just shows you how the demographics of the stress echo population compared to those who came into the trial based on the stress nuclear, which was the majority test, or stress MRI or exercise tolerance test. And basically, the populations are very similar. We had more women in the stress echo group and more Hispanic patients, but fewer Asians. For the Asians, most of the Asians that came into the trial came in through the exercise treadmill test because there's less stress imaging in parts of China and other parts of Asia. I think the interesting thing about more women in our cohort may just speak to the symptoms, and maybe the docs thought they had a lower pretest probability of disease. I don't know, because I think I've seen that stress echo compared to nuclear gets more of the patients who have sort of a lower risk coronary disease. The groups were pretty balanced, particularly when you look at incidence of hypertension, diabetes, things like that. The stress echo population had more patients with new onset angina compared to others, but EFs and other features were pretty similar. So I'm going to skip through all of this, but the other, I guess, important point is that more of the stress echoes were done with exercise compared to nuclear, where they had a higher prevalence of pharmacologic testing. I think we'll speak more about the coronary disease, but again, I'll I'll encourage all of you to read the paper or at least look at the tables if you want to get through, because table 1's a very, very big table. Now, table 2 in the paper really looks at features of the patient, demographics of the patients as a function of what degree of myocardial ischemia they had. Now, remember, ideally, to get into this trial, you had to have moderate or more myocardial ischemia, but there were a few patients that snuck in that had mild or no ischemia when the core labs actually looked at the stress test. The sites, after they were trained, were able to enroll patients into the trial and randomize them based once they passed some quality measures, but still there was when the core labs looked at the stress tests, there were some discrepancies. But if you look at the spectrum of ischemia, the angina that the type of angina, the quality of the angina they reported was pretty similar, whether you had severe ischemia on your stress test or mild ischemia on your stress test. And so I think I will, again, in the interest of time, skip through some of this. Other than an important point here, when you look at in table 2, when you look at the presence of transient ischemic dilation, what we found was that that finding occurred more frequently in those that had moderate and severe ischemia. So transient ischemic dilation is a marker of severity of ischemia, and certainly can use that in daily practice. Now, when we look at the stress echo and compare it or look at patients who had at least one 70% lesion on their coronary CT, what we found was that the odds of having that 70% lesion increased for every additional abnormal segment that we found on the stress echo. So, it sort of makes sense. The more ischemia you have, the more likely it is that you have a 70% lesion. So I think that when you're dealing in clinical practice with someone who has very mild ischemia, it's probably, they have coronary disease, but it's probably more like 50% lesions and less likely to be a significant lesion, unless they just didn't perform an adequate amount of stress. And we had a pretty good concordance, that is, positive of one type of test, positive with the other. So, significant 70% lesions and a positive stress echo, or no 70% lesions and a negative stress echo. So we had, concordances that were in the 80%, 80 to 90% range, which I think for a non-invasive test is pretty good. So I think in addition to correlating the stress echo findings with the anatomic findings on the coronary CT, and that is, how good is stress echo at diagnosing coronary disease, a very important point is its prognostic value. So on this table are some of our data looking at the outcomes related to stress echo findings. And you can see there's a group of patients that experience outcomes. And what we found was that the number of ischemic segments, although it was important in diagnosing 7% lesions, actually was not associated by itself with adverse outcome. The key feature on the stress echo in terms of wall motion for outcome was actually the presence of what I called infarcted segments, or segments that were abnormal at rest and continued abnormal throughout the stress test. So these were scarred segments. So scar was really a major determinant of outcome. In addition, there were a few other features that we can talk about. One of them is the ejection fraction response. On this part of the same table, you can see that if your ejection fraction increases by at least 10% with stress, you have a very low likelihood of having an adverse event. So that EF response is also very important. The transient ischemic dilation, which was correlated with degrees of ischemia, however, was not predictive of outcome. But again, wall motion score index did have a correlation in that if you had a primary endpoint, death, MI, hospitalization, you typically had a higher wall motion score index at peak stress than those who had no adverse outcome. So now on this slide, I'm going to very briefly just point out that the first column is the primary endpoint, but then we also looked at just death, cardiovascular death, or MI as an outcome, rather than that entire composite, and then all-cause death. And if you study this slide in detail, what you'll find is that I told you about the things that were correlated with the primary outcome, but and SCAR and EF were important. But if you look at just ischemia alone, it again it's borderline significance for death or MI. When we added the nuclear data, the nuclear perfusion imaging data to stress echo, because that was a really large population, it turns out that number of ischemic segments or some score of the degree of wall motion abnormalities actually was associated with development of myocardial infarctions. But again, you needed a bigger sample to bring that out. So I think that was probably one of the important points that comes out of this slide. And here you can see that, again, as the wall motion score index increases on the x-axis, the probability of reaching the primary endpoint increases. A is the total population, B is the invasive group, and C is the conservative, the medical therapy arm. And you can see that regardless of whether you go to the cath lab and get your vessels open, or go to surgery and get your vessels open, or just are treated with optimal medical therapy, this relationship holds. And so I think a key point in terms of looking at outcome, I think you want to look at the presence of scar on the arresting echo before the stress test. You want to look at what happens to your ejection fraction, and does it go up or does it go down? And if it goes down, particularly 15 percentage points or more, that's a marker of adverse outcome. And then also, as I mentioned, if you had ischemia in the anterior, moderate or severe, that is 3 or more segments of inducible ischemia in the anterior territory, that was a marker of risk for myocardial infarction during the follow-up period. And so I think this is just summarizes some of the things that we spoke about in terms of the more segments and EF augmentation being associated with significant coronary anatomic disease on the CT, and that SCAR and wall motion score index and EF response related to outcome. That transient ischemic dilation, which was associated with ischemic severity, but not outcome. And so I think those were really the key features of our study. Obviously, this is a population that is very focused. It's got moderate severe ischemia, and they're stable, and the EF greater than 35%. This doesn't necessarily apply to people with lower amounts of ischemia or left main disease, because we kicked all the left main disease patients out. And I think that that's important, because so we really have a very solid group of patients, but we don't have a wide spectrum of disease. We don't have the really minimal disease and the most severe disease. And so some of our echo parameters may not have been associated with outcome, just because we didn't have a wide enough spectrum of disease to really make that assessment. But even though I do think there are many features here that are practical and can be applied in clinical practice. So I think that we can say that stress echo is a robust technology for identifying significant coronary disease. It can be used to assess prognosis. And in addition to looking at the wall motion abnormalities, you want to look at the response of the ejection fraction to stress.
Great.
And I think that's
Thank you.
my presentation.
Wonderful. Thank you, Dr. Picard. So we're going to move on to some comments and questions. So Tony and Jen, this is where I'm going to get you guys to give your perspective. So I'd like to hear from both of you. So just first off, Tony, do you want to give some comments and then a question, and then we'll do the same with Jennifer?
Yeah, thanks. So this is a really interesting study, Mike. It's highly impactful, and the reason it's so interesting and impactful is that it really challenges thinking, right? It challenges conventional thinking, and that's what a good study should do. In a way, your findings are kind of counterintuitive, uh, and 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 I want to just explore that from a clinical perspective, or ask you to just get into that a bit more. Now, here in Canada, it's interestingly, of all the tests you've mentioned in your study, the one that's the easiest to get is the angiogram. And in a way, that's great because we can, it means we can intervene on people quickly, but it also means that we're often beginning the conversation knowing the coronary anatomy. And what that does, of course, is it biases us, right? We can't help but feel influenced by looking at those lesions. So let me ask you, when we're in those cath conferences and looking at that, how should this change our thinking? How should we be interpreting those angiographic and I know, and in the population that we're talking about, leaving out the left mains and all that. How should it change our paradigm of thinking?
So first, I would say in the United States, where I think we have a lot greater access to coronary CT angiography than you have, you could sort of say the same thing, is that many of our patients will get a coronary CT to define the anatomy. And the challenge that I have, whether it's the invasive angiogram or the non-invasive angiogram, is we've got the roadmap of where the disease is, but I don't know whether that disease is causing myocardial ischemia. And that's the value of the functional tests, particularly the functional imaging stress tests, so that I can then see which of those lesions that you may have already seen are the ones that are the most important, and the ones that, if you are going to intervene, those are the ones that you want to intervene on. Although, again, our data would suggest that you don't really have to rush off to the cath lab to take care of these patients. If you can put them on really guideline, the best guideline-directed medical therapy, that should take care of things, and so that you shouldn't even need that angiogram. And so, I think one could argue, if you had a way to exclude left main disease, then you don't really need to do that angiogram. And so, in the States, we would use the coronary CT. We wouldn't have to go to the cath lab to look for left main disease. And I think if that's the case, I should be able to then put those people on medical therapy. And again, as long as I can get rid of their symptoms, and as long as their ventricular function stays good, and they don't have progression of their symptoms, then I think I've taken care of things. If I've got patients with intolerable symptoms, that's, I think, when I want to say, okay, medical therapy wasn't sufficient, and let's go to the cath lab, because I know that with the intervention, in the intervention arm, those patients had a better reduction of their angina. And so from a quality of life standpoint, maybe that group benefits from the invasive approach.
So just extending that a bit further, and that all makes sense, but should our endpoint to guideline-directed medical therapy be purely symptomatic, or should we be looking at reversing the actual ischemic response? So should we be doing another test and making sure that that's changed?
That's a great question. Maybe you can educate me. I'm not aware of studies that have demonstrated adequately that the medical therapy reduces the stress echo findings. I just don't know if there's any studies on that. You would think that it would, or I hope it would. But I think it's two arms. I think that ideally we want medical therapy. We want the medical therapy to reduce the ischemia, and I'm presuming that that's what happened in that conservative arm, since they had the same outcomes as the invasive arm. So we must be reducing ischemia. But I also want to make sure that patient symptoms are improved. I mean, because that's probably what's bugging the patient more than anything else. Obviously, the ischemia it's getting at their risk of future infarction. So I do want to reduce that, which I think we are reducing with medical therapy. But I also want the patients to feel better, because if nothing else, they'll gain I will gain their trust.
So, Tony, are you asking whether doing a stress echo before and after optimal medical therapy has been shown to make a difference?
I'm willing to, I think we can accept the paradigm that if we can resolve the ischemia with medical therapy, then Mike's results suggest that we're on a good track and the patient's prognosis is pretty good, and we need not intervene. But my question is, how do we know clinically that we've resolved that ischemia?
Well, so if the angina improves or goes away, I have to think that I've taken care of the significant ischemia without even looking again. But it's the patients who have residual symptoms. Yeah. And there, I think the question is, okay, so then do you do another non-invasive test or do you just go to the cath lab? And I think that my approach would be just to go to the cath lab. I think there's a high likelihood that you're going to find the disease. And so I would just, whether it's causing inducible ischemia or moderate or more, I would just go to the cath lab at that point because I know I can get rid of the symptoms and I'm going to be able to get rid of the ischemia.
How would you assess the reproduction of chest discomfort in the context of the ischemia? So if you have a stress test and you reproduce the symptoms, everybody's feeling great, but a lot of the times the symptoms and the ischemic response don't connect, right?
Yeah. And that's why I actually would prefer exercise as a mode of stress rather than pharmacologic, so that I can assess the functional capacity of the patient. Because it may not just be chest pain, but I mean, if they have a low functional capacity, that tells me something that I think is an important finding. I think it's very hard, particularly in women. There isn't always a strong correlation between the symptoms and the amount of ischemia or the amount of coronary disease. And I think that's a real challenge. And I don't know that I have an answer for that.
I have some other things we can talk about, but maybe I'll let Jennifer.
Sure. Yeah. Jennifer, I'd love to hear your perspective, comments, and questions.
So I imagine that you all encountered some challenges with all of these studies coming from so many locations, kind of lack of standardization. That said, do you have any recommendations or any perspective on whether contrast-enhanced stress echo was, I guess, easier to interpret, yielded better results or closer correlation versus non-contrast enhanced images?
Good question. So let me start with, we had these over 30 sites around the world enrolling and randomizing patients. And so what we started, let me tell you how we tried to get as close agreement among sites as possible. We first started by training all the sites. And they went through webinars. They had to submit cases to us to show us that they could actually get good imaging, even before they did patients, and also send us cases that demonstrated no ischemia, moderate ischemia, so they really could see what they were doing. And then, as they enrolled patients with the stress echoes, those cases came to the stress core lab, which was me at Mass General, and patients had the sites had to have at least 10 correct assessments of moderate or more ischemia before I felt comfortable that they could then go off and start interpreting the tests or having their interpretation be the gateway into the trial. So we really worked hard. The patients or the sites that sent us cases where they called it moderate, but we looked at it and said, no, it was less than moderate. We then had teaching sessions. So we really spent a long time actively teaching sites how to do this. But it's still some cases snuck in, even though we sort of passed cases. We used the most recent ASC guidelines on stress echo as the sort of the textbook, if you will, or the protocol. But sites, the use of contrast was at the discretion of the sites. And a lot of these sites were from overseas where they didn't have access to contrast. I can tell you, as the person who read all the echoes, it was much easier if we had a contrast-enhanced echo than a stress echo than a non-contrast. But the reality is that less than 25% of the stress echoes were with contrast. Would the results have been different? That's a good question. I don't know. I bet you that we might have had better agreement. Those few cases that had no ischemia or mild ischemia, I bet those would have been recognized with contrast and gotten excluded from the trial. But I think that even in an individual lab, it's really important to have, if you've got multiple readers or reading the stress echo, having, a conference like which we used to do, where you sit down and everyone sits at the table, looks at the same stress echo, and you go through and decide how to interpret it. Does everyone agree which segments are abnormal? Is it akinetic? Is it hypokinetic? Is it just one territory? Is it in multiple territories? And I think everyone has to learn together so that your lab interprets the test the same way, because I may interpret the test one year and then the next year I'm not there that day and Amer is reading it, and I need to be comfortable that his interpretation approach is going to be the same as my interpretation approach.
And then one more question. How were patients with bundle branch blocks dealt with in this study? Because I imagine there must have been some percentage of them with that.
There weren't that many, believe it or not. With a right bundle, there's really no issue, because right bundle branch blocks really don't impact wall motion, but a left bundle will definitely impact the wall motion. And what I find is the left bundle will basically bring or cause the septum to move in at a different time point than the lateral wall, and it will actually come in later. And so what I'll do is, if I have a stress echo where I see a really wide QRS or the EKG shows left bundle, and I should also say, in the core lab, we didn't have access to the ECG, so I didn't know who had bundle branch block and who didn't. But if I saw something that made me concerned of a left bundle because of the septal motion, what I do is I edit that study and I only look at the second half of systole. Because in the second half of systole, that's when, in a left bundle, if it's normal myocardium, that's when the wall is going to come in. So if you look at just the latter half of systole, I can then get a better assessment whether that wall is still moving abnormally or whether it's moving normally. And in that case, I can make the interpretation. Now, the problem is, once I shorten and only look at the latter, let's say the second half of systole, that is going to move really, really quickly because I've lost that full segment. So I've got to not only edit the duration, I then have to play it at a slower speed so that I can actually see the wall motion. So there are ways to look at a stress echo in a patient who has a left bundle. We don't like to do it. It takes a lot of work. You have to have a really good PACS system that allows you to do all that editing to do that. I think that nuclear perfusion imaging sometimes has a similar problem. So I think we're all in the same boat there. That's a good question.
And then, is there any continuation of this work or any future projects planned in this area?
Well, it's a great data set, and so there's a lot of things that we can do. We've done a few things. We've been looking at strain, particularly in the ANOCA. I didn't even tell you about what we have, a subpopulation of patients who had a positive stress echo, but then on the CT, they didn't have any coronary disease. So they got thrown out of the trial. But we followed a group of them, and we have echoes both at baseline and 1 year on those patients. So we've been doing strain to see whether the strain patterns, even though they have wall motion, is there something different on the strain that maybe correlates better with the CT, the lack of coronary disease on the CT. So that's something we've been applying, because we can apply, with strain, we can do strain after the fact on a lot of these image sets. There's another question that we've been interested in, and that we have a small but reasonable size group of patients that had myocardial bridges on the angiogram, the group that went to invasive angiography, that have myocardial bridges. And there's some data, I think it's from Stanford, where they've looked at some stress imaging tests and findings and how they relate to myocardial bridging. And so we've talked about doing that. Parenthetically, I haven't been able to find a fellow interested in taking on that project. So I need to get more bodies to help me with some of these things. But there's a lot of things. In fact, if there's people listening in on this, if you have questions or hypotheses you want to test, we may have the data to be able to do that. And we're always looking for collaborations.
Very interesting. Thank you, Jen. Great questions. Tony, you had a couple more questions.
Yeah. So, Mike, one of the great contributions of the study is you've provided us, I think, a standard for positivity. So the definitions you've provided around what you called a positive study, I think I think every echo lab that does stress echo is going to have to look at that and think about how it now reads positive. But the reality is we don't get a lot of positive studies in the usual clinical world, Um, and the ones you described, I think nobody could argue with. I think the ones who have, good contractile response, all the walls thick and the cavity gets smaller, we're good with those being negative. But there's a lot of people in between, right? A lot of people who get to target and don't have a full positive response, but have what I would call a blunted response, right? So that they don't thicken well, that their cavity doesn't change very much. And I guess my question is, how do you interpret those? What do you say to the clinician about those studies? And obviously, they have to be, the decision has to be, rendered with a broader perspective of the patient situation. But as a reader, what do you say about those?
So the first thing is, let's look at pharmacologic separate from exercise. So on the exercise patient, we really want to make sure that they reached an adequate amount of exercise, and so that we've really put enough stress on the myocardium and really increase the oxygen demand. So a patient that barely does 2 or 3 minutes, the heart rate goes up, and they're probably deconditioned. I think I end up having to say that this is an indeterminate test for what you described. On the other hand, for the pharmacologic patients, if I get to 40 mics, we typically will extend that to 5 minutes instead of 3 minutes. Keep looking. Also, we'll have a patient squeeze a tennis ball to try to increase afterload, try to do something, or you could even have maybe patients pump their legs, but do something in addition to the dobutamine to try to increase the oxygen demand, to really be sure that we've had an adequate stress test. And I think that, just like with treadmill testing, there are times when you just have to say there's an indeterminate test. Patient didn't reach certain targets. And, the value of the stress echo is that maybe we don't need the heart rate target as much because we really look at the inotropic response. If you've got a patient where the ventricle, the wall motion pattern stays exactly the same, so, the amount of wall motion is exactly the same, I actually worry about those, that's 3 vessel disease, because really the normal response to an adequate amount of exercise I should see some increase in the wall motion, in the contractility. So the fact that it doesn't really makes me worried, and it's obviously hard. It's much easier when I've got one wall that's moving in normally and the other one is wimpy, because then I can say, yeah, there's definitely a wall motion abnormality. But when they all don't come in, I don't know if that's just inadequate or if it's truly bad disease. And I think that's a group that you really have to watch out for. And I think that's something that most labs fail to recognize.
I have the same worry. Yeah. Thanks for that.
And sometimes you just have to do a second test.
Yeah. So I was going to ask you about that. Do you bring them back and try again, or?
I know. I think. I look at things. Were they on a beta blocker? Well, if they were, yeah, then I might try to do it. Can I do it off a beta blocker? A lot of times we won't even do it. We'll send the patient home and say, we need the beta blocker to wash out for a day, and then we'll come back again. But there's some patients where, because of their blood pressure, or they're really hypertensive, or there's another reason, we'll test them on beta blockers, which is another interesting, we didn't talk about here, but in the group that we tested on beta blocker, if they had 3 or more wall motion abnormality segments, that's a group that's really had a high degree of adverse events. So that's a really bad prognostic sign. If you can get a bad ischemic response on beta blockers, that tells you there's a lot of disease. But to go back to a second test, I typically won't do a second stress echo. Whether I do a stress nuclear instead, I might. But most of the time now, where I am, coronary CT is so available and so easy to get that we'll just go right from that functional test. We'll go to the anatomic test to look. And, if it's an indeterminate stress echo and there's minimal coronary disease on the CT, I feel relieved. And if there's significant disease, then I probably go against my tenets and say, even though I don't know the functional ischemic response, I see enough anatomic disease that I probably would go to the cath lab. And if the patient's, got reasons to fix it, fix it.
Right.
It's a tough, I think those are tough cases. But again, stress contrast may help with those too, getting better imaging.
Yeah, the issue I find with contrast is you got to be sure you're actually getting the whole ventricle. There's a tendency with the contrast to foreshorten to make the contrast better. So you got to make sure the images are the same. But
yeah, and I think the other thing with contrast to keep in mind is that when you're at the peak stress, you don't need as much contrast because the stroke volume is so revved up. You want to make sure you give a less amount of contrast so that you don't over opacify the apex and lose your ability to see the distal part of the ventricle. So if you're going to do contrast, it takes a little bit of work. There's a learning curve to using it during stress echo, I think.
Yeah, thanks for saying that. Get time for another one, Amer?
Yeah, I think I want to bring it to the panelists now and just talk a little bit about stress echo in general. Like I feel that we're at a right time to really examine how stress echo should be performed, sort of clinically. There's so much change happening. For example, is there value in incorporating strain? And I've been doing work in carotid ultrasound, so adding other parametric type of imaging, integrating with other modalities. I'd like to hear, Tony, from you, what your perspective is on quality. And Jen, what do you think are challenges, especially with training and performance? So maybe Jen will hear from you first and then hear from Tony.
Yeah, I've been thinking about that, listening to this whole talk. For us, our volumes have really dropped in the last decade. We perform about 25,000 echoes at this facility, and last year we did under 500 stress echoes. So we try to balance it as far as the number of sonographers that we train. That way, at least, those few studies are done by the same core group of people. Right now, it's 4 people that have performed those 500 studies. But I agree. There's lots of technical challenges. When I worked at the MGH, it was predominantly bike exercise. So you could image, during and after. There wasn't that downtime of getting folks off of a treadmill and onto a bed. Here we rarely do supine bike stress echo. It's all, the treadmill, catapulting them onto a bed and trying to get those images. But the other challenge, I think, is also familiarity with contrast. How to administer it is definitely one piece that we really have focused in on, but also the machine settings. And when you add a contrast preset to a system, it significantly drops your frame rate. And that has been one of our challenges is being able to truly visualize diastole, systole. And, when we were talking about the ejection fraction component to this, it made me think like maybe we should be taking an off protocol full 3 cardiac cycles before going into just the systolic assessment, improve that accuracy. But yeah, frame rate and staff experience and comfort in it is definitely a challenge.
And that could be sort of a vicious cycle. If you have less people comfortable, then quality can go down as well. So is that the trend? Is stress echo?
I think we're noticing the same thing. At least in the States, coronary CT has really blossomed, and it's good because you can look at plaque morphology. There's a lot of things you can do with the CT, and I think we're seeing less stress echoes. And this week there was a new guideline document out on training advanced cardiac, non-invasive cardiac imaging training. And in there, they have, I think it's 150 stress echoes as a criteria for training. And I think that's going to become challenging for many centers if you've got multiple fellows for each fellow to get that number of stress echoes under their belt. So I'd be interested to see how that pans out. I predict there's going to have to be some adjustment to that number.
So are we not advancing and innovating stress echo enough such that it's losing a little bit of its attractiveness in clinical practice? Should we look at a reset and reinvigoration of stress echo? What do you think, Tony?
Well, stress echo is actually getting more common in clinical practice, certainly in Ontario. If we have the opportunity through the quality assurance process to track this through labs, and I can tell you that stress echo is expanding dramatically in its application through the 600 or so sites in Ontario where echo is provided. And that's good. I mean, I'm a huge advocate of stress echo as a tool, and I think it has huge potential. But here's the but. It's tough. It's the most demanding thing we do in the echo lab, I believe, both from the technical and the interpretive perspective. And being trained in transthoracic echo and wall motion is not sufficient to be able to reliably interpret stress echo. We need to respect the technology and the requirements to read it. I mean, those of us who've been at it for 100 years still shake our heads about lots of the images we get and aren't sure. So we need to respect the training requirement, and we need to be really, I think, respect the idea that you can't just jump into stress echo from transthoracic without having an immersion experience in a lab that does a lot with a lot of people around you. I mean, when we read them, we commonly ask our colleagues to look at it a second time or hold it back or, work with the sonographer on getting images. It's a very demanding thing to do well. And when it's easily, when the ventricle blows up and it's easy. When it's completely normal, it's usually easy. But I really worry about false negatives because both false negatives and false positive are dangerous, right? The false negatives, you're going to miss folks that may have disease. The false positives, you're going to send people for testing and worry that it maybe wasn't needed. So it's a demanding and valuable, but we need to respect the technique.
But when you talk about innovation, Amer, I think that we need to keep an eye on artificial intelligence because I think here's a place, it probably isn't going to be able to help us with improving the quality of the images we get, but in terms of the interpretation and quantification of the wall motion, I think there's something there, and because we may not be able to see the border, but if you can get into the guts of the image, there's a lot in that image, whether it's the strain and all the other things. So I think that, some smart data scientists should be able to apply some AI techniques to the quantification and interpretation of stress echo, and that will help us, and particularly, as Tony said, because then you've leveled the playing field in terms of the ability to do that interpretation.
Well, in your comments earlier about strain, I mean, we haven't touched that, right? And I think that could be a big game changer because it's the acquisition is not, I'm not saying it's easy, but it's a little more straightforward.
Mm-hmm. But
the heart rates are your cardiac cycle is so much shorter that you don't get as many data points during systole, which also makes.
But I think
machine adjustments could do that, right? We need more pixels to do it. So we could be looking at different protocols for strain than we're currently using.
Thank you. Great discussion. And I feel like we need to have more discussion about stress echo. So wonderful. We're going to move on to our next portion. Excuse me. And this is where we get to know about our panelists and our esteemed speaker. So first, we're going to ask Dr. Picard to show a picture or a piece of artwork that's important to him, has some meaning to him. So we're going to call that up onto the screen. And Dr. Picard, would you like to tell us about the image you selected for today?
So this is a photograph I took. My wife and I have a cabin out in the Pacific Northwest on one of the San Juan Islands. And this is a view looking west from our deck And we're on Orcas Island, and across the sound there is Shaw Island, and you can see it's at sunset. And this is a place that I go that I really enjoy, a place where we can do hiking, we can do cycling. I have an office where I can sit and do my writing, and there's an eagle nest nearby, so we've got eagles that fly by. So it's a place that I get to really go where I can unwind from the digital world.
And not too far from Canada, it sounds like.
It's actually it's closer to Canada than it is to some parts of the United States. Yeah.
Yeah, that's amazing. Thank you for sharing that. And next, Tony, Dr. Sanfilippo, would like you to tell us a little bit about this picture.
Well, I didn't choose this picture, but it's a great picture. This is of my hometown. I grew up in Collingwood, Ontario, which is north of Toronto on Georgian Bay. When I was growing up there, it was a town of 8,000 or 10,000 people. A lovely, lovely place to live and grow up. This harbor, which now contains all these lovely pleasure craft, when I was growing up, contained a big steamship that was being built, because these were shipyards.
Wow.
And that terminal was where the grain was transported to the Great Lakes, to the western provinces and states. So it was just a lovely place. It still is a lovely place. My mom and my brother and sister still live there, so I visit frequently. And it's now actually a great center for medical training, believe it or not. There's a regional hospital there that our learners go to and learn family medicine and many aspects of medicine. So it's a lovely spot.
Thank you, Tony. That's so interesting. Thank you for sharing that. And next, we'll have Jennifer share a painting. And Jennifer, you mentioned that this painting is called something to do with Hearts on Fire. Can you tell us about the painting?
So this painting is by an artist named Amer Johri, who currently lives in Taos, New Mexico. But he's originally from France. So as I was looking at Dr. Picard and Dr. Sanfilippo's images of the ocean, it kind of reminds me of a little bit about my journey. So I grew up on the East Coast on the ocean, and for some reason I've just been drawn to the American West. So the painting is called Heartbeats, and it just reminds me of, wide open spaces, and I have it hanging in my office for all those days that I sit here without a window.
Beautiful. I really like the colors and the movement that's being captured with the horses there. Very nice.
His clouds are just next level in all of it.
Yeah. Wonderful. Thank you so much for sharing, guys. That brings us to the end of today's discussion on stress echo and the insights that we gained from the ischemia sub-study published in the June 2025 issue of the Journal of the American Society of Echocardiography. Thank you again for joining us on today's podcast.
So, Amer, I want to really thank you for organizing this. And it's really been a lot of fun. My favorite podcast is Conan O'Brien Needs a Friend. And I just listened to it. But this was even better than that, and really entertaining. And I hopefully, we learned some cool stuff. So really thank you for organizing this.